Hi, everyone. I'm just giving it a few more seconds to let people sign on, and then we'll get started. Okay, good afternoon, and welcome to ASCO's Online Clinical Educators Forum, otherwise known as OCEF. I'm Dr. Amy Moy from the New England College of Optometry, and I'm also the chair of the ASCO Clinical Affairs Committee, which is bringing you this forum through the support of the Clinic Directors and Administrators SIG. Today's program will feature Eyes Wide Open, AI-driven teaching, and retinal imaging breakthroughs. We have a great lineup today, and I'm looking forward to hearing from our speakers, Dr. Timothy Bossi from the New England College of Optometry and Dr. Clint Prestwich from the Chicago College of Optometry. They will continue our theme of using artificial intelligence in clinical teaching and practice. I'd first like to acknowledge the Clinical Affairs Committee members, Dr. Andy Archilla, Dr. Don Gody, Dr. David Hall, Dr. Basant Labib, Dr. Vaki Nataraja, and Dr. Candace Turner, as well as the SIG liaisons who serve on our committee. Thank you to this year's OCEF Chair, Dr. Don Gody of OSU, and Vice Chair Dr. Vaki Nataraja of CCO, who both volunteered to steer this program and effort. Thank you to our presenters who have taken time from their busy schedules to impart their wisdom with us today. And thank you to Ms. Jennifer Rubin, our Clinical Affairs Committee staff liaison at ASCO, and Ms. Molly Mills of ASCO, who's helping us to run smoothly today. So thank you. And thank you to our on-site OCEF liaisons for helping us spread the word at your campuses about this important program we have for you today. Just a few requests before we start, and maybe I'm on the wrong slide. Yes, just a few requests before we start. If you're watching as part of a group, please make sure that you have each attendee sign an attendance sheet and send the final sheet to Jennifer Rubin at ASCO. Please take a moment to double check that you are on mute. Please remain on mute throughout the duration of the event, and we'll be accepting questions in the chat during our Q&A portions of the program. Please keep your camera on if you're a presenter or moderator during your section you're presenting. This meeting will be recorded for posting on ASCO's YouTube channel, which can be found on the ASCO website. Ms. Rubin will send a SurveyMonkey link to each registrant shortly after the conclusion of the program. Please complete this survey so that we can utilize the information for future planning. And now, for an exciting pop-up question, please answer in the chat, and this is our attempt at interactiveness, so please humor us. What is one way you use AI in the clinic or in teaching in general? I'll give you a few seconds to think and type in the chat. I'm seeing open evidence, patient education. Some are still learning, getting broad strokes on a condition, some general disease info, especially differentials for shaping exam question, summaries of long reports. Awesome. Thank you, everyone. Summarizing comments to students for MetaTrek. That's a good one. All right. Thank you, everyone. Feel free to keep adding, and we'll take that into consideration for future AI content. And now I'm going to turn it over to Don Gody to introduce our first guest speaker.
Thank you so much for the background, Dr. Moy, and for the housekeeping notes. I would just like to add that you can put your questions in the chat at any time, and we will do our best to answer them by the end of the presentation or later in a summary. At the end of each speaker's presentation, Dr. Basant Labib, Vice Chair of the Clinical Affairs Committee, will moderate a brief question and answer session. And now on to the forum. We have wonderful speakers today, and the first of which is Dr. Tim Bossi. Dr. Bossi received his Bachelor of Science in Biology at the University of Maine and graduated with his Doctorate of Optometry from the New England College of Optometry. He is currently the Senior Director of Owned Clinics and Outreach Services and an Assistant Professor of Clinical Optometry at NECO. He oversees the NECO's Center for Eye Care Commonwealth in Rosendale and NECO's outreach clinics. Before serving in this role, Dr. Bossi was a clinical and residency director at Lynn Community Health Center in Lynn, Massachusetts. Outside of clinical practice, Dr. Bossi also lectures at NECO on glaucoma and is the instructor of record for the patient care class for the third-year students.
Thank you for the introduction and good afternoon, everyone. I want to say thank you to ASCO for providing me with the opportunity to be here today as a part of the 2026 Online Clinical Educators Forum. So thank you, and also thank you all for being here today. So over the next 15 to 20 minutes, my goal today is to kind of highlight where AI is already being integrated into patient care, more specifically optometric and ophthalmic care, and then what it means for us as clinical educators. And this higher overview that I'm going to provide will then help serve as a transition to Dr. Prestwich's presentation, which will expand upon some of the concepts that I'll cover. Preparing this presentation, one of the things that stood out to me was I'm going to be really sharing some of my experiences. So discussing current trends, right? Consistently emerging evidence. It feels like every day we have changes. I just had an article this morning I was reading and shared with a bunch of colleagues. And then some of my, like I said, experience with these AI tools as a clinical educator. So I'm not going to be able to provide necessarily all the answers. I think I'm trying to, outline where we can work together and where we should continue to look as AI evolves. So here's the title of the slide today: How AI and retinal imaging are changing optometric education. And we'll keep moving along here. So, growing role of AI in patient care, and I think the first few bullet points here are pretty obvious. I'm sure you've had conversations about AI, and with Dr. Moy's question early on, it was really interesting to hear where a lot of you have already integrated AI into patient care or didactic education. But I think this helps us frame where we start today. So we know AI is increasingly becoming more integrated into patient care. Still some challenges we're facing, but we're likely to see that move forward. It's present in optometric education. We talk about this all the time at our faculty meetings and have, meetings about how faculty are using AI to improve upon their teaching strategies. There's continued integration. With this continued integration, it's definitely going to reshape clinical competence and how we're preparing students to integrate AI into care. So that's a lot of what we're going to talk about today in terms of teaching domains. And then we have to continue to think ahead. And I think that's why it's so important for us to look at these trends and look at the literature. It's really hard to stay up on it every day, but it allows us to start to think ahead about how we can shape didactic and clinical education, especially clinical education, which is what we're here to talk about today. There's some objectives that I have listed here, and these are more just to guide our discussion, not necessarily any sort of fixed conclusions that we're going to come to, but just points to help us move forward. So we're going to hope to understand where AI is entering optometric care, and there's some certain areas where it's definitely grown faster than in other areas, and we'll talk about that. Consider which teaching domains may need to change or we may need to alter in response to where AI is now or where it will be in the future. And then number three is explore retinal imaging as a practical example of AI-driven changes in clinical care. All right, so where are we now? And I think you could make this list go on forever. I really tried to summarize it in some broad areas. So retinal imaging and AI image review. Diabetic retinopathy actually was in the early 2000s. They started talking about using artificial intelligence to screen for diabetic retinopathy. It was the first standalone software program to independently diagnose in all of healthcare. Was related to diabetic retinopathy. So it's something that's existed. It's something that, we've continued to expand upon. And as a part of that, now we're seeing that emerge into OCT analysis as well, screening support of patients, and then also referral support. So helping to make referral and management decisions. Clinical documentation and support AI, and I have a slide, later on, which I really want to talk about this topic, but forming your essentially your history for your patient, right? Forming your assessment plan at the end, having after visit summaries or letters formed, and communicating with patients using AI in those areas. Clinical workflow AI, so triage routing, having patients answer questions through AI, having AI then help you dictate where that patient should be routed, when they should be seen, along with follow-ups and alerts. And then other forms of patient communication, which I've had quite a bit of experience with in terms of direct patient to AI conversation, answering patient questions using artificial intelligence. And then other areas such as educating patients about their findings, their exam findings or lab findings. That's kind of where things are now. And you can see how it impacts all aspects really of the care we deliver. It's not really necessarily focused on one area, right? It's really, their pre-visit, their visit, and their post-visit. We have this AI integration in all those areas. So I don't want to break down this whole slide because we're gonna go more into specifics related to teaching domains, but we know that in those areas we just covered, and since they're going to be involving really all aspects of patient care, that's going to cause us, to have to start to shift or think about where we would plan our teaching moving forward, right, in certain domains. And that's really this slide's just to highlight that. So the first teaching domain I want to talk about is image acquisition and quality and assurance. So earlier on, I mentioned that diabetic retinopathy was the first area that we had a lot of this AI-driven technology integrated. And I think that relates to image acquisition and quality assurance, right? So, traditionally, if an image was poor, we would, say either ourselves or we would say to the student, let's go take that image again. As we start to integrate AI more into this, we have to realize that a poor image may still generate an output, right? And that output can be based off that poor image. So it's going to be particularly important for us as uh, clinical educators and to make it clear to students that we really need to have a thoughtful process in terms of image quality, gradability, the artifacts that we have in images, and segmentation failures. And that's not just the fundus images, but that's also for OCT imaging and all the other diagnostic testing areas that we're really seeing this uh, AI integration occur. So we have to understand that bad input is bad output, and we're going to get a bad output. We need to understand that it is bad, and how do we go and fix that moving forward. So it's not just going to be a technical skill as far as image acquisition is related. There's going to be a lot of clinical reasoning and understanding of the diagnostic procedures being performed, and then also how do we analyze and interpret those outputs in an accurate manner. And as a part of this, when we talk about seeing images and recognizing disease, I found several pieces of interesting literature specifically on this and the training of less experienced users. So I included a study here, which what they did was they exposed the trainees to a large number of actually AI generated images, fundus images that included different diseases all throughout really the posterior segment of the eye. And they took pre and post diagnostic quizzes as a part of this. And as we know, exposure, especially for students, is one of the strongest drivers that we have in terms of improving competence. And that's really in a lot of different areas. With this research that they did, you can see where, and the image is really small on the screen that I have, so I hope everybody can see it. But as they move forward, they were able to improve the trainees' diagnostic accuracy because of this exposure and consistent exposure to seeing images and images with disease. The diagnostic accuracy improved from 43.6% to 74% on ultra wide field, and then 42.7 to 68.7 on standard images. So over this course of the program that they ran all these trainees through, the improvement in diagnostic accuracy was, quite substantial, which you can see there. So, that continues to show us if we're going to rely more on diagnostic imaging, that it's going to be ever important for us to continue to expose students to retinal images and retinal images with disease to build their interpretation skills. Teaching domain number three, so clinical reasoning and AI integration. And I should say that, as I worked through this, I was thinking about where we assess students now in terms of their competency. And there's a lot of foundational things that I don't feel like changed much in terms of myself right now as a clinical educator and what I'm looking for in terms of competency. It's really those foundational things don't change as far as me not integrating AI too much right now versus how I may in the future, right? We know the clinical reasoning and being able to self-assess and interpret data is going to be important, and that's not going to change with AI integration. It's just going to change in terms of how we're doing that and what data we're reviewing. So as a part of clinical reasoning here, what I wanted to point out was that it's really important for us to teach structured processes as we begin to integrate AI more and more, because AI is not going to always give reliable or consistent answers to students, right? There's going to be things that they're going to need to work through, and having a clear process will help them maybe not rely on AI too early. It'll help them identify if there's errors, and then also it'll show and demonstrate how they can apply their clinical judgment appropriately. Um, I think one of the things that's going to be very interesting to see, and I've seen it on a couple of occasions, is, if a student's clinical thought process that they independently form first before looking at the AI output is different than what the AI output is, how will they work through that? What tools will they use in terms of clinical reasoning to work through the differences in their thought process versus what we get from the AI output? And ultimately, that's going to be a very important tool that they have, and they're going to need to work through that in really a structured and safe way. I have an example here just in terms of OCT. So, the student, you take an OCT, we really should be encouraging the student to interpret the OCT first, have their same sort of approach that, they do now without AI in terms of making a diagnosis, interpreting the image, thinking about their follow-up, and then review the AI input. And either, it's consistent with their thoughts or they need to reconcile, sorry, those differences before they make a final judgment for that patient. And that's going to be important. And that this is more on an individual level that I'm talking about. But I think one of the other areas where we're going to see AI really start to push us forward is healthcare delivery in terms of teams. So interprofessional education. And this, the article I read this morning made this really, really clear, that we're going to see this continue to grow in terms of collaboration between eye care, optometry, ophthalmology, right, and primary care doctors. We know that it's already established now with diabetic retinopathy screening. Yes, there's challenges towards launching diabetic retinopathy screenings on a large scale, but it's still definitely happening right now. And in terms of emerging areas, the slide here I thought was really incredible in terms of fundus imaging and all the areas we're looking at in terms of retinal biomarkers or oculomics. So, if AI does continue to progress in this way, it's going to be really, really important for us to understand how to play an important role in these large scale collaborative healthcare environments. And students are going to need to be prepared to also function in these environments, depending upon the healthcare setting that they're learning in. So this is the domain. Really, the article I read this morning was most focused on, and I think it's one that I'm the most excited to talk about today because when Dr. Moy asked that question earlier, I think this is the area that we're seeing a lot of growth in terms of AI use in clinic, and that will also be important again in terms of us teaching students. So the teaching domain number four would be documentation, case history, and generative AI. So generative AI is expanding faster than any other area of AI integration into healthcare. And really with limited supporting evidence. Out of all areas, this is one of the areas that's really the lowest in terms of supporting evidence based on specific tasks that generative AI is being used for. There's been a lot of studies recently about generative AI. The AMA published a study from earlier this year, a survey essentially where they had over 1,800 physicians respond, and 72% of physicians right now are using generative AI with at least one case. And you can see this slide over, or the image I have on the right. So already using is the darker purple, light purple, we'll call it, is the expect to utilize within 1 year. And you can see that generative AI is, if it's looking up, having AI summarize literature on a particular disease or um, generating chart summaries, translation services, right? Creation of patient education. All these areas are really big. And I think we're going to see over time that these 72% of physicians are not just using one aspect of this, but this is going to expand even more rapidly because of the efficiency that it helps to, it helps us all with. It's just going to be ever important that there's evidence there to support some of the tools that we're using, especially because it's inpatient care. There was another study I looked at with ambient listening. I don't know about all of you, but I've had a lot of people approach me about, try our ambient listening software. I think a lot of our electronic health record systems even are starting to integrate that now. So AI-driven ambient listening. And I don't know how many of you are using it, but that's going to be ever important. If we're going to use that software, especially with students, they're still going to have to understand how to take an appropriate case history, how to read through data and understand what is important, right? And what matches with the type of care that they're going to be delivering. Because this study that I was reading really talked about hallucinations. So the AI system, as it's ambient listening, making things up that it thinks it hears and putting that into different aspects of the exam record. So documentation may shift from really students independently taking that information, but they're still going to have to know how to be critical and evaluate the information being output by AI, and how that integrates, into the care that they're delivering. I'd love to hear from anybody who's using ambient AI, by the way, in a clinical teaching environment. Just there's a lot that could be discussed related to that. So if you are, please reach out. Teaching domain 5, we're almost there, is AI literacy and ethics, and also patient communication. So, I was working through this because on the next slide, I'll talk about an activity that we just did as a faculty at our retreat recently, and it really was an eye-opening experience for me. But AI integration, really, we've got to look at ways that we can continue to involve AI integration throughout the curriculum. And it's going to be really important that learners understand what AI can do, what it can't do, what the tool we're using really can do and not do, different limitations and biases. Can we apply this AI OCT software or fundus AI integrated software to the patient population we're actually seeing, right? Does it match the patient population we're going to try to apply this to? When they need to override the tool or it's not working for a particular patient. And I think as we move forward, we're going to have questions from patients about these tools and how or what we used as a part of these tools to make decisions about themselves. So AI literacy is going to become ever increasing, very, very important. And then I'll get to what we worked through. So we asked at our faculty retreat, which we had recently, we worked together to ask all the different AI models or a handful of AI models, kind of this gray area clinical question. And it was just eye-opening. It really was because I didn't have access to all of these models before this to see how the model responded, what it asked us to clarify, how it came back to us with questions before it would make a decision, and how long that would go for. And I think it became evident that, they're really different, the AI models themselves, and, that we really need to be specific in terms of how we're prompting them and how we're trying to, drive evidence-based decision making out of those support tools. So we've had, several lectures on applying evidence-based practice, and there's a lot of literature about this in terms of how to prompt and use AI to drive towards evidence-based practice. And I really encourage you all, if you haven't, seen that or haven't had any support from your college or university in that area, to look at that because Very, very interesting to see. Almost done here because I know we're on a time crunch, but I think these are the competencies that we're going to continue to have to look at. AI literacy, obviously very important. Image acquisition, continuing to expose students to taking diagnostic images and looking for reliability as far as artifacts, exposing them more and more to images, especially images of disease, to help build their diagnostic capabilities, specifically related to imaging. We know that clinical reasoning is always going to be important, but it's going to be how do you integrate this new approach to clinical reasoning with AI-driven data output, communication, again, another important foundational thing that we already teach, but how do we educate patients about how we're making decisions with AI, and make sure that's clear to them as a part of their patient care delivery. And then there's a lot of ethical points that, we won't get into today, but obviously going to be important. So traditional precepting, what do you see on the fundus exam? And we may shift now to, is this image gradable? What does the AI output show? And do you agree with it? What do you see on this OCT report? So I think encouraging the student to review this OCT independently and then compare it with the AI output, and where do these two things differ? So we're just going to say things, I think, a little bit differently as AI continues to become integrated. And don't get me wrong, we're all going to have our own I'd say approach to integrating AI, and it may be at different speeds and at different levels. But if things continue to move forward the way that they are, we may all be asking these same sort of questions in terms of precepting. So lastly, AI is already integrated, and we're seeing that. We heard from a lot of you and how you're using it. Foundational skills are still going to be critically important, but we may just need to shape those skills a little bit differently in terms of AI-supported workflows. It's going to change, AI will change how we teach, and not just the tools that we're using in patient care. And it's going to be very important for us to ensure that students are using AI in patient care in a safe, evidence-based way moving forward. And thank you for that. Happy to answer any questions.
Thank you so much, Dr. Bossi. That was excellent. I will invite anyone to throw your questions into the chat, and Dr. Bossi can answer them there, so that we can move on to our next portion, which I'll now turn over to Dr. Nataraja to introduce the second part of our program.
Thank you, Dr. Labib, and thanks, Dr. Bossi, for that amazing presentation. As a contact lens person, the Retinal AI, great update. But moving on to our second speaker, someone that I know very well. So this is Dr. Clint Prestwich. So Dr. Prestwich received his Bachelor of Science degree in Neuroscience at Brigham Young University, and his Doctor of Optometry degree from the Southern College of Optometry. He completed residency training in pediatric optometry and vision therapy at the Southern California College of Optometry and is now on the faculty at the Chicago College of Optometry at Midwestern University. He currently serves as the Assistant Director of Clinical Rotations, and Dr. Prestwich is very passionate about optometric education, and he's currently enrolled in the Master of Health Professions Education program at the University of Illinois, Chicago. So thanks so much for being here, Dr. Prestwich. So now I'll turn it over to you.
Thank you, Dr. Nataraja. Thank you, everybody, for this chance to talk about something I think is really pertinent for what we're doing on a day-to-day basis right now. And thank you, Dr. Bossi, for that really great kind of introduction of what we're doing currently with AI in the clinical setting and how it's going to affect how we train our students moving forward. However, I want to kind of set the tone for what I'm going to be talking about for the next 45 minutes or so. So first of all, I have a brother who works in information systems design, and he would just laugh if he knew that I was talking about AI because he considers me a very not technical person. And so my approach when I talk about this, when I discuss AI, is that first I'm an educator and I love education and I love thinking about how to be a better educator and the tools that we can use to be better educators. And so the way that I think about AI and the way that I approach this presentation is how can we use AI to solve some educational problems that we often encounter. So that's the kind of general frame of what we're going to be talking about over the next about 45 minutes or so. And we're going to go over some really specific use cases of ways that I have used it in my teaching and in ways that it can be used. And some of the things that we're going to be talking about have been mentioned in the chat, which is wonderful. But there's a couple things that haven't been yet. So I'm excited to go through this with you. And if we have time permitting, there will be some time to practice. So if you have a favorite LLM, AI LLM that you use, get that fired up, because we're going to be have some time for some practice as we move through this presentation. So let's continue. So I have no disclosures. I will say I mentioned several products during my presentation. I have no endorsement of these products. They are just the ones that I used, and I have no relationship with any of the products. So Dr. Bossi kind of addressed this already. You know, artificial intelligence, is it a benefit, or is it something that's going to impede our teaching? And the questions I want you to consider, if we were in a small group, we could discuss this as a group, but in a webinar, we can't really do that. But so just think about it. You know, how do you use AI in your work already? So some of you already answered that question, but think about that. Those of you who haven't, what makes AI intimidating for you? Think about that. What exactly makes it so that it's hard for you to use AI, or to take that plunge to start using artificial intelligence in your day-to-day work? What advantages does AI provide for clinical education? I think Dr. Bossi laid some of those things out really well. Possible advantages that we might see as we are starting to educate our students around AI and with AI. And then what challenges do you see? You know, what challenges does AI pose for clinical education? So this is not something that is unique to us by any stretch of the imagination in the optometric community. If you go to PubMed and look up artificial intelligence in clinical education, or in health professions education, or medical education, you'll see dozens and dozens of articles. This is a hot topic right now. So many publications about it. But this one in particular, I really liked because they ask a question. The author asks a question. He says, will AI help reshape medical education for the better, or does it risk deforming traditional pedagogical approaches by fostering over-reliance on technology and eroding essential humanistic skills? And I think that's the kind of core question that many of us are facing when we think about AI. Can we use AI as a useful tool, or is it going to overtake us? And I think it's the former, and I think we need to be intentional about it. So I think beginning to use it in different contexts opens up our eyes to how we can use it to really help our students rather than create harm for them. So objectives for today. I'm gonna just provide some resources that can be used to implement AI in clinical education scenarios, and then demonstrate some really specific use cases. I have a lot of screenshots where I show the prompt that I used and some of the output that I got from these different models. But it's really going to be focused on solving these educational problems with artificial intelligence. So to open, I want to just talk about some educational challenges. So we are all educators, and we work with students in different formats. Sometimes it's one-on-one, sometimes it's in groups. We have these lots of different challenges that may come up, and we face them on a daily basis. So things like, we have clinical grading inconsistency, meaning if you're an administrator and you have two different preceptors grading the same student, they might give you totally different grades, right? Based on what they saw the student do and based on what happened. So there's clinical grading inconsistency. You have things like student engagement. So as was mentioned in my introduction, my specialty is in pediatrics and vision therapy. And I have to tell you, I love vision therapy, but a lot of our students, when they come into our vision therapy clinic, they are just not engaged. And so how do I do that? How do I, as an educator, get them engaged in something that they maybe don't really want to do for the rest of their career? How do I establish that? That's a real problem. How do I assess competence for these students? How can I know that they're actually competent? You know, is it based off of one exam? Is it based off of a whole quarter's worth of exams? How do I actually make that determination? So that's a really pertinent clinical question. Things like preceptor training. So if you have a new faculty member, or if you're working with our external preceptor sites, how do we train preceptors how to be good teachers? How do we train them how to guide our students in the way that's going to be helpful for them? How do we help poor communication skills? You know, those of you who have ever sat in on any brand new third year's exam, some of them are great and some of them are not. And listening to them try to communicate with their patients can be very painful. So how do we improve that? You know, how do we help them move along that path so they become better communicators, so their patients can receive the care that they need. And finally, Dr. Bossi, he hinted on this. We're going to talk about this later, but evidence-based training. How do we make sure that the evidence that our students are finding is real, that their decisions are based on evidence that has actually occurred, that's not hallucinated, it's not made up, and how do we guide them to those sources? So those are lots of different educational problems that we're facing as educators, but the ones I want to talk about specifically today are these. So how can we use AI to confront some of these problems, like clinical communication, providing adequate feedback, maybe filling the gap where we have a lack of virtual learning tools for optometry, providing some quality supplemental teaching materials, teaching evidence-based medicine, and then also finally talking about clinical grading and how we can use AI to do that. So problem number one, clinical communication. So, also I used AI to generate most of these images. You can see Gemini's little sign there in the bottom. Very handy when I'm doing these presentations these days. But how did you learn to be an effective communicator in a clinical setting? So just reflect on that for a minute. How did you learn how to be an effective communicator? And is that different than how we're teaching students how to be effective communicators now? Is it the same or is it different? I think for the most part, it's probably pretty much the same. I feel like most of us learned how to be effective communicators by listening and hearing and being in the room with good clinical communicators. I'm sure many of us can think of preceptors that we've had in the past that really guided us and mentored us and helped us to understand how to talk with patients and how to get across important ideas and concepts and how to have difficult conversations. But there can be a lot of things that are difficult about that process. What if the student doesn't come across a certain situation before they graduate or in their training? How can we help bridge that gap? If they happen to see a certain type of disease a bunch of times and they never see another type, maybe they're not as comfortable educating a patient about that type. And it's important to remember that when we're discussing clinical communication, students are now formally assessed on their verbal communication and professionalism. So in the new Part 3 exam, there is a score for that. They are scored on their communication and professionalism. We have to make sure that we're teaching our students how to communicate with their patients. Our patients have to understand what they're being asked to do, and it's our job to teach them how to do that. So how can AI then help us train our students to be better communicators? So the primary way that I've come up with when I'm thinking about this, and there's probably dozens of ways, but we can use artificial intelligence to act as a simulated patient and then provide feedback to the student on their performance. So there's a couple different ways that we can do that. One is this third-party platform. It's called SimConverse, which I will talk about briefly, and then we'll go into more detail using some large language models. So first of all, let me talk about SimConverse. So SimConverse, we do use that here at Midwestern. It's a project I've been involved with for the past 2 or 3 years now, and it's a great platform. The advantage of it is that it allows for creation of specific virtual characters, formal rubrics, and assignments. So essentially, SimConverse is as a third-party platform where you can access and you can create characters, you can create case scenarios, you can create rubrics, and then you can combine those things into different assignments and assign them to your students. Your students do them on their own time. It can be on a tablet or a phone or a computer, and they interact with a virtual patient, and that virtual patient talks to them. So it is a verbal interaction. So the virtual patient can talk to them, and they respond back, and everything that is discussed in that virtual patient encounter, there's a transcript of it, and then using a rubric that you have created, it will grade the students on their performance. So there's detailed monitoring of student use. It provides immediate feedback to the students on their performance. So there's a lot of advantages to it. However, it's not cheap. I'm actually not aware of how expensive it is because I'm not involved in those discussions. I'm involved in the build. But I know, talking to people who are involved in some of those discussions, that it's not cheap. And so there is a financial investment for SimConverse, and it is a third-party application, meaning that there's some features that you may want and they may not be available to you. So it's a great platform. But if you want to talk more about it, you can contact me offline. I'm happy to discuss kind of our experience with it. But what I really want to focus on today is using artificial intelligence large language models to do a similar thing. So to act as a simulated patient. So it's not quite as fancy, obviously, but it can do something, it's a little more accessible. So what you can do is you can write a prompt. It can be written freehand, or you can use a structured template. But the prompt that you're going to use for this type of encounter or this type of educational opportunity is, first, you need to discuss who's involved. So what does that mean? You want to identify yourself. Identify yourself as a student. Are you a teacher? What are you doing? Identify yourself to the large language model, and then also tell the large language model, the AI platform, what you want them to be. So they have to become this patient. They have to simulate a patient encounter. So you have to give them the details of that. So what are the patient demographics? What's the personality of the patient? Are there specific personality traits? Are they going to be kind of abrasive? Are they going to be really friendly? What's the condition that they have? So on and so on. So you have to get some context to the large language model to see if they can, so that the large language model can then simulate that patient as best as possible. So other context you want to give is task identification, meaning you want to help the AI to know, or the model to know, what are we actually doing? Are we taking a case history? Are we providing patient education? What is it? What is it that we are actually doing with this simulated patient? And finally, it's really, really helpful to define the feedback. So that's part of that prompt, is you're going to define feedback, meaning I want you to give me feedback in a certain way about certain things. And that provides, if we can give them the structure, then we can get really meaningful feedback back. So we need to talk about who it is, we need to talk about the context of the encounter, and then give some context for the feedback as well. So that's kind of the bare bones of what a prompt needs to include, or should include. So I want to show you an example now. For my examples that I have today, I primarily use Copilot, and I did that for a few reasons. One, because I know there are some limitations in some institutions on what types of AI platforms you can use. However, if you're a Microsoft institution, my understanding is that a lot of people can use Copilot, maybe if they're not unable to use ChatGPT or Gemini or other types of AI models. Those of you who joined the OCEF in presentations in the fall, Dr. Turner, who I'll talk about a little bit in a minute, she called Copilot trash, which is fine. It's not as strong as other large language models. And so my other reason for using Copilot is I want you to see that it's accessible, that even though it's not the best AI model, it's actually can do a lot of things. And it can do some things that I was surprised that it could do. And even though it's more limited than other models, if it's the one that's available to you, you can still use it. So first example here. So I set it up. I said, I'm a third-year optometry student learning various clinical skills. I am practicing how to educate patients about their diagnoses and treatment. Will you please act like a 55-year-old female patient that is a little abrasive and unwilling to listen? She has proliferative diabetic retinopathy and is scared about what that means. She has several questions about how we will treat her. So that's kind of the context. And then I want to here's some of my feedback. So at the end of the conversation, will you please grade my performance on a scale of 1 to 4, with 4 being the highest, and in the following areas? So effective communication, professionalism, and accuracy of the statement regarding the diagnosis, cause, and treatment plan. So that's my prompt. And Copilot was like, sure, I can do that. Here we go. And so the role play started. And now this was just text coming back to me. So this wasn't verbal from Copilot, though I believe you could set it up that way if you wanted. So the patient says, wait, what do you mean I have proliferative diabetic retinopathy? That sounds serious. No one ever told me anything like that before. What does this mean? Am I going blind? All these different things. And so I will say my responses to this, I did verbally. So there's a way on Copilot, you can just hit the mic and it'll record, it'll dictate what you're saying. And so that's what I did here. So I said, nope, ma'am, you're fine. You're not going blind. This is a common condition. And luckily there are several treatments. Then she got a little more angry with me. She didn't like knowing that this was common, and bear with me, I'm a peds doctor and I was firing from the hip here, but she was scared. And so that came back. And so I tried to calm her down and I gave her this big long thing. I'm not going to read it to you, some of it because it's embarrassing. And however, at the very end of that, what they did say, what Copilot told me, is like, hey, here's your scores. And for communication, they gave me a 3 out of 4. They said, you use clear everyday language to explain a complex condition. But then they gave me an area to improve. So it's a bit rushed, which I would agree with, and slightly disorganized, which I would also agree with. Breaking into small digestible parts with pauses would help. So I agreed with that um, grade, I suppose. Professionalism, they thought, Copilot thought I did a really great job on professionalism, that I was calm and respectful. And then my accuracy of diagnosis, they gave me a 3 out of 4. They thought I wasn't as accurate as I should have been talking about the cause of the diagnosis. So it gave me a little bit of feedback there. So that's one example. So well, I thought, well, that's great when I kind of sort of did okay. So what does it look like if I don't do okay? So this one I set up close to another scenario, act like a 15-year-old who is apathetic, doesn't want to be at the eye doctor, has a CI and is frustrated at school. He wants to know how we're going to treat him. And then the grading was the same. So Copilot said, sure. I like the sighs loudly. They're illustrating that for us well, but sighs loudly. I don't even want to be here. My mom made me come. She says I'm having trouble reading, but I can see fine. So convergence insufficiency, what is that? It sounds fake. I don't know if I've ever had a patient be quite this abrasive, but it's still fun to do. Now, in this case, I decided to not do a good job. I decided to respond very poorly to see how the AI model would grade me. So I responded with, stop complaining. Your mom cares about you. It's not fake. Your eyes don't work very well together. Quit complaining. And the patient responded appropriately to that, probably told me to chill out, and asked a few more questions. So at the very end of that, I got some scores. So from Copilot, told me I was not a very effective communicator. And the strengths I laughed is like, you attempted to explain the diagnosis. So not a whole lot there. Areas to improve. Came off as dismissive and confrontational, which I agree. And it gives me some tidbits here. Empathy is key with adolescents, which I thought was very nice of them to give me that little tidbit. And then professionalism, 1 out of 4. Don't tell a patient to stop complaining or to quit complaining. That's not a way to gain rapport with your patients. Instead, you could say, I know this isn't your favorite place to be, but your mom brought you here because she's worried about how school is going and so on. So they gave me some examples of how I could do better, not just telling me that I didn't do very well. And then finally, they gave me a 3 out of 4 on my accuracy of diagnosis, cause, or treatment plan because I was right. And what I recommended was good. I just didn't present it in a very helpful way. So there's an example of a bad example of how Copilot can possibly, or a large language model can give feedback to students who are not responding the way that they should. So we're going to practice really quick. We're going to practice really quick. We'll take 2 minutes. So open up your favorite large language model AI and try to set up a little prompt. So remember, set up the who, the context, and then the desired feedback of what you want back. And I'll give you about 2 minutes to set that up, and then we'll keep going. Right. I'm going to continue, but I hope you're able to I know that wasn't very long. I'm looking at the time, and I want to make sure that we're done in the next half an hour or so. So we have a few more examples I want to go through, so we may not have a whole lot of time for practice, but I hope that you were able to maybe start on some of this and think about how you could create some of these clinical scenarios with simulated patients for your students to practice with. Maybe if you have downtime in clinic, or maybe it's an assignment you can send home. So problem number 2, providing adequate feedback. So a question to consider is, what are some barriers that prevent providing meaningful feedback to students after clinical encounters? So we provide feedback in different ways. Sometimes it's every encounter, sometimes it's every day, sometimes it's only, at summative points at midterm or at the final. But we always are providing feedback to students. And there's a lot of barriers to that, one of which I think is student attitude. Sometimes a student is not really receptive to feedback. And that's usually more on the daily, the daily feedback you're given, or maybe some of that verbal feedback. Additionally, sometimes learning environment's different. So if you're in a really, really busy clinic, it can be very difficult to provide adequate feedback. But ultimately, I feel like time is our biggest limiting factor. We are educators, and most of us know how to provide pretty good feedback to our clinical trainees, but we're often limited by time. We're overseeing multiple trainees at the same time. We have a busy clinic, we're in a busy environment, whatever it might be. So time can be really limiting. So the question I thought to ask is, how can AI help us provide meaningful, intentional feedback to students to improve clinical performance? Can AI help us save some time? And to do that, I used a tool that was provided to us at the last OCEF by Dr. Laura Turner. So she created this really, really cool optometry-specific AI prompt builder. And she went over it in detail at the last OCEF, so if you want to check that out, you can. I'm going to show you some screenshots of it because I used that to help us help solve this problem of providing adequate feedback. So what I did, so this is a kind of a screenshot of the opener of that website. So if that link that you saw on the previous slide, you can go to this website, and it has all of these different things. And in the previous OCEF, Dr. Turner, she went over a lot on the task decomposition kind of canvas and how to work with that. But we're going to go today to these track templates. So with these track templates, what you can do is you can pick, she has pre-built prompts for us. And so what I did was actually track C, which was learner support. And here on this learner support, there is this set prompt. And it says, you are a faculty coach providing informative feedback on a student, and it gives the audience, has these different inputs, and all these different steps that you're giving to the AI model to answer these questions for you. So you can just copy that template, and then put it into your preferred large language model, which is what I did in Copilot. So I just took that template straight from that. Thank you, Dr. Moy, for throwing that in the chat, the link to that. But I took that prompt, and I filled it out. So I decided to try to tackle a scenario where you're signing your charts at the end of the day, and you see an assessment plan that a student wrote, and it just isn't very good. It's just not very good, and you're trying to figure out how to provide some feedback on that assessment and plan, and how to provide actionable feedback that they can then improve and get better on. And so this is the prompt that I used. And so I said, you are a faculty coach providing informative feedback on an electronic health record assessment and plan that's been de-identified from an optometric exam. Your audience is a fourth-year optometry student who needs constructive, growth-oriented feedback. So the inputs, I just told it to use a grade rubric on a scale of 0 to 3, clarity, accuracy, and professionalism. And then I just copied and pasted the A&P straight from the HR. The idea identified it, obviously, but I copied it straight over. This particular patient had an alternating esotropia, some inferior oblique overaction, and there was this plan that was outlined here. And then I finished the rest of the prompt, and I said, what do you say? And this is what it came back with. So it said they did okay, which is about what I expected. When I read that assessment and plan, it kind of felt like an okay one. It wasn't great. But it gave this very kind of this feedback of 2 out of 3 for clarity, accuracy, and professionalism. Continued, and it said things like strengths to reinforce things they did well, and then actionable suggestions for improvement. So you can separate the education from the management. There's a specific phrase in here which I was really glad it highlighted, because when I read it, I was like, yeah, that's really not a really great phrase. And it was likely vision therapy to solidify. That doesn't make a whole lot of sense. And it gave an alternative phrase, which was, vision therapy recommended to improve binocular function. Which is a much more professional type of phrase that you can use in an EHR that's not going to cause you issues later. So it even gives some model phrases of like, this is what you could have said instead. And then you can give a clarifying question for reflection. So a reflection question that the patient can ask, or sorry, the student can ask themselves at the completion of this activity. So this is a really fast way of generating some meaningful feedback to students when we may not have a whole lot of time to do so in the moment. But if we have a little bit of time later, we can throw this into an AI large language model and get some really specific feedback for our students, depending on what you're throwing in there. So I think I'm going to skip for the rest of this presentation. I'm going to skip the practices. I'm sorry. We're running a little shorter on time. I have about 20 minutes or so left. And so I want to get through some of this material, but please practice with this. I want to make sure that you understand that I tried to pick some things that I could do, and I'm not very good at tech. So if I can do it, I'm pretty confident you can. But I would really highly recommend that you go to this website from Dr. Turner that she developed for optometric educators and look to see what's possible there and use it to generate some feedback for students. Problem number 3. So lack of virtual learning tools. So what I'm talking about here is that our students are online and they're looking for virtual tools to help them learn. They live on their iPads and their computers, and many of these tools exist, but they may be problematic. They're often not specific to optometry. They have poor information sources. There's a lot of things that exist, but optometry, we're pretty small in the medical and the health professions education world. We're pretty small. I was looking it up. I think there's just over 7,000 optometry students in the country. I think there's over 100,000 medical students. There's like 27,000 dental students. So we're a pretty small population in the health professions education world. So there's a lot of stuff out there that's not really specific to us. And so what can we do then to use AI to help us maybe develop some things? So how can AI help us design applications that can be used as learning tools? And so as I was preparing for this presentation and in the past, I stumbled across something called vibe coding. Now, when I first learned about this, it was last year, and I said, is this a real thing? I've seen it a lot more in the news in the last few months. I think it's becoming a lot more mainstream. But I wanted to describe what vibe coding is. So when we all know what coding is. When we're designing applications, information software engineers, they write code to get that application to do whatever they need it to do. Vibe coding is using AI and using plain language. So I can just type into AI, create an application that does this. And through an iterative process, meaning go through multiple cycles of what that application looks like, we can maybe eventually get a final product. And there's a couple of cool papers I'll note here at the end that they did this with some medical educators, and they were able to design some applications in a relatively short period of time. So I thought, well, if they can do it, maybe I can do it too. So I decided to try it, and I decided to do it on Copilot because that's what I said I wanted to do. And I did this. It was actually during one of my clinic shifts when I was between patients. I would see whatever kicked out, and I'd give it some more feedback, and we just kind of went through this iterative process. And so I want to show you what that looked like. So my first prompt was very, very basic, and I did that by design. I think you can start with a much better opening prompt than this, but I did it very, very basic because I wanted to see what can it actually do? What can we get if I am coming at this from a very, very beginner level with a very, very basic prompt? What will happen? And so this is what I said. So I said I asked it to create an application that third-year optometry students can use to practice NBEO PAM-style optometric cases. And I said, okay, great. And asked me some questions like, do you want a clickable prototype or write the backend logic? And I was like, I don't know what the second part is, so I'll say the first part. I want you to create a clickable prototype of what this would look like. And it said, okay, great. This is what it's going to have. And I said, cool. I clicked on it, and this is what it looked like. And I thought, well, that's interesting, but it's not exactly what I was looking for. So I gave it some more feedback, and I asked it to kind of expand on the cases because that was very limited case information. I wanted more cases. I wanted a few other things. So it continued to build, and it came back, said, do you want me to extend this prototype? And I said, extend it, multiple cases. I want a dashboard. I want comprehensive case data for each case. Start with 20 cases. And it didn't really change it. So I thought, okay, what do we have to do next? So I said, continue refining the application. Each case should include comprehensive case information, and then each case should have 5 to 8 questions. Add real clinical images for each case. And so it said, okay, I'm going to do this. I'm going to do We're going to start with 3 cases though. So this was the feedback back to me, and Copilot told me I'm going to start with 3 cases for demonstration, and then we'll keep going. So what's funny is that sometimes it wouldn't work, and it would say, I would click on it and it says it doesn't work. Well, and so then I would go back to the AI and I say, your application doesn't work. And they're like, oh, you're right. Do you want me to fix it? And I would say yes. And then they would fix it. So that was really interesting. I wasn't exactly sure what's happening. I just knew that it didn't work. And so I would then ask it if it could fix it, and then it would fix it, and then it would work after that. So that happened a couple of times when I was working with Copilot, that I had to tell it to fix it, and then it did. But sometimes when I click on it, it would look like something like this, and it wasn't super helpful. Eventually, though, we started making some progress. And we started having something that looked like a little bit better. Still not a whole lot of case data. So I kept asking it to expand on that. And eventually we got to more case information. And all of the answers there are listed. So when we got to this point, I said, great, I want you now to expand this to multiple cases. And so I did that. And I said, make it look a little prettier. It gave me a copyright down there at the bottom, which I thought was funny. And make it a little prettier, make it a little more easy to read, and expand it to a bunch of cases, which it did. But then what I found when I was digging through each one of these cases is that this app that had developed, all the cases were the same. So I said, well, you got to make the cases different. And we worked through a bunch of different iterations. And eventually what I discovered is that Copilot wasn't able to create more than about 3 cases in an app like this. When I asked it to do things beyond that, funny things started happening like this. So if you look closely at this, it looks okay first, but then you look at the bottom and it's like the answers don't actually make sense. There are no answers. There's option A, B, C, and D. So that's not really helpful. When I continued to push it, sometimes it would come up with things like 2023 visual acuity and a refraction of minus 1.3 diopters. So data that now was no longer realistic. And this tended to happen through this iterative process every time I asked it to push beyond about 3 to 5 cases. If I asked it to do more than that, it really couldn't handle that. So I scaled it back, and eventually we landed on something that looked like this. And so this was the dashboard. You could look at this, you could click on the case, and once you click on the case would pop up, and it gives you all the information that you need, ask you a question about that case. You're able to then click on one of those radio buttons, submit your answer, and when you submit your answer, it tells you if you're right or wrong, and gives you a little bit of an explanation for that answer, and then you move to the next question. So I thought, well, that's really cool that we were able to do that for 3 cases, but that's not super helpful. And so then I thought, well, what if we create a way in this app I can put in the information for the case, and then it'll just import it. And it said, sure, we can do that. So then it created this form that I could fill out with case information, and I can export that case. You can see that button down there at the bottom. It says export that case as a JSON. And if I export that case, I had another button on my app that I could then import a case and create cases on my own. So the creation of the cases was a sticking point, but not the creation of the app. And so we worked around that, and we worked on some of this case creation where I can put in the data, upload that case, and then import that case to this app that it worked. So that was my experience there. Now I'll say that whole process that I just talked to you about took me, again, it was between patients in a 3-hour clinic session. So we were able to go from make me an app to a workable app where I could then import case data that I wanted to include to create more and more cases that I could then potentially then send my students this URL that they could use to practice at home, which I think is a pretty cool thing. So again, we don't have time to practice, but I would really encourage you to try this. Try this out. If you have some free time at some point, try some vibe coding. See what you can come up with. These are prompts here so this one on the left is the one that I used. These 2 here, on the one in the middle and the one on the right, come from this paper that's cited below, where this is the prompts that they use to start their web-based apps, and a lot more detailed. So that can be a model for how you want to maybe build what's your app that you're thinking about. So this is really fun. And it's a little funny too, because you're talking back and forth with this large language model, and it's a fun process that I learned a lot from, and it was actually pretty short to give me a usable product. All right. Next. So problem number 4, quality supplemental teaching materials. So Clinics are busy, as I already alluded to, time is limited. Often instruction is needed beyond what can be provided in the moment. And this is for all the people who looked at that last presentation or like, Dr. Brestwich, there's no way that I can vibe code. That is way beyond what I'm comfortable with, and that's fine. So, but if you still want to create some supplemental information for your students to help them study, to help them learn, this is what I want to demonstrate for you. So it can be difficult to generate meaningful homework for our students. If there's something that you notice in the clinic that are not performing the way that they should, what can we give them so they can improve that performance outside of the clinic? So often, in the past, you'll tell students, review your notes or, look up some articles on this. And that's really not helpful. Those of you who've ever read reviews will know that if you have preceptors who are telling your students that, then students don't appreciate it, and they want something more. They want something more concrete and actionable to improve their clinical abilities and to study outside of clinic. So the question then is, how can AI help us create meaningful supplemental educational materials? And the first idea that I had when I was thinking about how we would do this is we first have to identify an educational gap. So what problems are your students regularly struggling with? What is it that comes up over and over again in clinic? Maybe for a specific student or maybe for a group of students. What is that? What are you encountering? Then you got to think about how to close that gap. So what I mean by that is this foundational knowledge. Is the reason there's this gap is because they have something foundationally is off. They don't have that knowledge, that knowledge base that they need to make this decision. Is it application? Meaning, do they have the foundational knowledge, but they're unable to apply it correctly in a given scenario? They can't use that knowledge correctly to make good clinical decisions. Or maybe it's not even that. Maybe they can do it on a typical patient. Maybe they're really good at seeing our standard patients with our standard conditions, but anything that comes to them outside of that, they struggle. Maybe that's how we need to close that gap. So then what we're going to do is, once we've identified the gap and we identified what we need to do to close the gap, what specific area we need to work on, we can then create an AI prompt to generate appropriate material. So that prompt can be really detailed or it can be basic. A lot of the things on Dr. Turner's website would be great to maybe generate some of those prompts if you want a really detailed one, or it can be a really basic one like I'll show you in a minute. Additionally, I want to do a little shout out. So ASCO recently published their preceptor toolkit, and in section 3 of that preceptor toolkit, that's called Teaching Strategies, there's a little AI prompt bank. And so if you can just Google ASCO Preceptor Toolkit and you go to section 3, there's a little AI button and you can click on that, and there's a bunch of really great AI prompts that you can use to generate supplemental educational material. So again, I'm going to show you some Copilot examples here. My initial prompt was, I want you to create a worksheet containing 5 optometric case studies to help a 4th-year optometry student better understand the decision-making process when prescribing glasses for a pediatric patient with hyperopia. So this is a classic problem in a pediatric clinic. Prescribing glasses for hyperopes for kids is very nuanced and very tricky. So I was curious to see how this would be handled. And Copilot was like, yep, I can do that, no problem. So it created this worksheet, and it said this pediatric hyperopia prescription decision-making. And from here, we can go, it gives us a bunch of different things that, that the student is going to be asked to do, whether to prescribe, how much plus, lens type, follow-up strategy, all of those things. From there, there's a list of cases. And these cases, I just picked this one. So this was case 3 that it had demonstrated there. And it says hyperopathy esotropia, and it gave me all this clinical data. And then the questions that it asked of the student is this. Is a spectral correction indicated? What would you prescribe? What's the primary treatment goal? How would you counsel patients regarding this? What additional management steps might be required moving forward? All these different things. So these are decision-making questions that was built into that worksheet that I asked Copilot to generate. Now, you might be saying, Clint, this is really great that can create this worksheet for them to do, but what about the answers? And it can do the answers too. So that was actually, it finished the worksheet and it was like, do you want me to give you an answer key? And I said, sure, give me the answer key. And it did. And so this was the answer for all those things. And it said for this case with hyperopia esotropia, you should give the full cyclo, which is a pretty standard answer and is correct. So we want to correct that high hyperopia with a constant ESO with our full cycloplegic refraction. That's a pretty standard response. And kind of gives some context of why that is and how to counsel the parent and some additional management questions. So I feel like this was a really pretty straightforward. This took me maybe 5 minutes to generate, maybe not even that. So if you have a session with a student where something didn't go well and you want to give them some more practice, it's really easy to jump on to a large language model and ask it to create a worksheet for you that you can then give them, print it off and give it to them. And they can work on that at home. And then when you see them again, you can work through it with them and work through some of these answers, or maybe just give them the answer key and have them work through it themselves, whatever you want to do. But it's really straightforward and it's really pretty accurate as far as I've seen. Now, as Dr. Bossi mentioned earlier, and this is true for all AI, we've got to really check. We've got to really check some of this stuff to make sure it is creating accurate cases and accurate answers. You always have to do your due diligence. You can't rely fully on AI. But it's a way to do the initial work for us, and then we're editing rather than creating. And it can be a really powerful tool. So again, don't have a whole lot of practice time here, but I would encourage you to try this with some of your students. Problem number 5, teaching evidence-based medicine. So I'm sure most of us have gotten this question at some point from one of our students that we're working with in clinic. What's the evidence for that treatment? Why did you decide to do that? And sometimes it's challenging, but often it's students that are really trying to understand. We're really trying to understand, why is it that we made the clinical decision that we did? And what can we do? What are they supposed to be learning from this clinical encounter? So for some of this stuff, it's really easy. Our landmark studies that are really well known, it's really easy to justify a decision. But sometimes, especially in optometry, there's not a whole lot of landmark studies on some of our clinical decision making. And maybe there's just a lot of nuance in how we're deciding how to move forward with these patients. And so using AI to find evidence can be very difficult. A couple things I want to mention. AI, large language models, speak with authority. And as humans, we are wired to listen to authority. And so students will ask questions of AI and it gives them an answer, and it says it with authority. There's confidence in that answer. And so people just kind of assume that it's right. And I'm sure that most of us have encountered that at some point. Anytime you do any type of Google search, you'll see an AI thing at the top, and it'll say, this is the answer to this question. And then if you actually look at the source documents, it's not actually the answer. And so it can be really confusing to students when AI can speak with such authority, when it's not really an authoritative answer. Additionally, Dr. Bossi mentioned these hallucinations, and they're a real issue with many platforms, especially with the generation of citations. So, and those of you who are doing peer reviews, you may have seen some of this already. I know I have, doing some peer reviews. I've seen some hallucinated sources that sound really good. They have really great sounding titles. The authors are people that work in the field of study, and the journals are those who would publish it too. So it sounds really good, and then you go to look to try to find the article, and it doesn't exist. It happens. It's happening. We need to be aware of it, and our students are going to come across it. I mean, in fact, I had some students that pranked me with this. They created an article, and they said, hey, what do you think about this article? And I was convinced for about 10 minutes that this was a real article, and I never heard of it before, and I was really confused. But it can be really believable, and so it can be really difficult to use AI to find really good evidence. So I wanted to mention, in addition to that, students are not very good at finding hallucinations. So this was a little study that was done, and they were just looking at, students' ability to detect hallucinations, and they weren't very good at it. Their conclusion was GP trainees have a limited ability to recognize ChatGPT generated hallucinations, particularly in complex clinical scenarios. So our students aren't very good at it. So we need to make sure we're directing them to good sources. There are a lot of AI platforms that are designed for clinical decision making. Some of them I've seen in the chat already, which is amazing. I'm going to give you a quick example of open evidence. So these AI platforms that are designed for clinical decision making often may require an NPI. So it's really just used by healthcare providers. So I want to give you this example of open evidence. So I recently had submitted a prior authorization for some vision therapy treatment, and it was denied. So then I had a peer-to-peer. So in preparation for that peer-to-peer, I did some research on vision therapy for treatment of IXT. And I found some cool articles that I wasn't aware of, some recent RCTs that I thought, okay, great. There's some evidence for what I'm asking for. And so that process, finding those articles, probably took me 30 to 45 minutes. I'm looking on PubMed and a few other places. So I decided when I was preparing for this presentation that what would open evidence tell me? And so I just put in a very simple question: what evidence exists for treatment of intermittent exotropia with vergence and accommodative training? And sure enough, it says emergent evidence shows that it works. And it cited the same articles that took me 45 minutes to find it, found in 30 seconds. And the same articles they're from PubMed that document the successful treatment of IXT with vision therapy. So just a kind of really simple example of something that could have saved me some time. And if I'm working with a student and they say, what's the evidence for that? I can possibly use open evidence to help me find some really good evidence. So I would encourage you to try this. Try this on some of your most common clinical questions, or think about a clinical decision you've made in the last week or so and ask these specific clinical decision-making AI platforms for some evidence for that decision. All right, last thing, and then we'll wrap up. Clinical grading. So this is a really great textbook talking about assessment in health professions education. And in it has this quote. It says, assessment has been a major preoccupation and topic of inquiry in health professions education. This is quite understandable considering the high stakes involved in making sure that examinees have a suitable level of competence to go on to the next level of training or to practice independently. So basically, one of our jobs as educators is to assess our students. And that can be a hefty responsibility. We determine if a student should continue in a program. We determine if they should graduate. We determine if they're ready to move on to the next year. But sometimes it can be very difficult to make that decision, to make that summative grade. Meaning the daily feedback is sometimes a little bit easier, I think, because you saw an interaction or you saw a session in the clinic and you're able to give some feedback based on what you observed. But then generating an overall grade, a summative decision based off an entire term, that can be difficult. So the question I asked is, how can AI help us provide summative grades for our clinical trainees? And so the way to do that would be to upload a rubric that you use. And that rubric can be something like, it's an Likert type scale. So that's what we use at our clinic. We have a meets expectations, above expectations, below expectations, unsatisfactory, exceeds expectations, I think, or excellent. And so that rubric is anchored. So there's descriptions for every domain. For an efficiency domain, there's going to be descriptors for what it means to meet expectations and what it means to exceed expectations and so on. So that can be a rubric that you can use. There's grading standards, things like they should be completing this exam in a certain amount of time. You can also use ASCO's published competencies as a rubric. And then you need to upload all the feedback. So you can throw your rubric and you can throw this feedback that the student has received over the course of a term into the AI, and it can help you come to some conclusions. So I did that. I said, I'm trying to decide this midterm grade for one of my fourth year optometry students. And this was my initial prompt, really basic. And it said, okay, great, we can do that. I need you to give me this information. And this is what it asked for. It asked for the rubric, and then it asked for the feedback itself. So I uploaded both of those things. Now I will clarify that I made sure I de-identified everything. So there was no identifiable material from the student or from the preceptors or anything. It was just the feedback itself and then the rubric. And it gave me grades for all the different domains that we use. So our first domain is case history, said it was satisfactory, and it gave me some really defensible rationales based off the feedback that student had received for that grade. And another domain, it gave a below satisfactory, based off of the feedback that was given to that student. It seemed to think that they should get a below satisfactory for this specific domain. Overall, it gave me an overall grade as well, an overall midterm assessment, meaning, overall they did okay, but here's some areas specifically to work on. So if you were to meet with the student, you could talk about these areas of focus for that student moving forward for the rest of that quarter or the rest of that semester. So it was able to do it very well. Now, I was curious, how does this compare to the grade the student actually got? And actually this co-pilot was a little harsher on our student than we were as faculty. They gave a few more below satisfactory grades than we did as faculty, but I really appreciate some of the ways that it's able to summarize the feedback that's been given into defensible rationale for some of the grades that was provided. So I thought that was a really useful tool, and I plan to probably use that in the future. So in the interest of time, we're not going to practice this, but I would really encourage you to see what you can do to help, or what ways that you can you can utilize AI to help you provide some summative grades for your students. So in summary, to close, AI can be a powerful tool to help provide solutions to complex clinical education problems. It can help us in all these different various ways that I went over today. Important to remember two things. One, it's okay to just get started. It doesn't have to be perfect. It's okay to start with rough prompts and try to work your way through it. It's okay to use maybe not the best platform. Try to use one that you're comfortable with or one you have access to. But when you're doing that, make sure you're using it correctly. Make sure you're being aware of what the limitations of AI are and that you're using it in such a way that you can benefit your students. So AI can be problematic if it's not used correctly, but it is our responsibility as educators to teach and demonstrate its effective use. Thank you.
Thank you so much, Dr. Presswich. That was a great presentation. We do have a couple minutes if you want to throw your questions in the chat for Dr. Presswich to answer. And if not, I can start with one. So when you use AI, whether it's in the clinic or in education, do you put in a disclaimer that some of the material is AI generated, or even for patient materials that Dr. Bossy touched on? Is that somewhere in the resources that you develop or provide?
You know, that's a great question. I haven't used AI to create a whole lot of like formal documents, but yeah, I'm open with students to the fact that I use AI in these ways to help summarize comments and to provide feedback. I think it's good for them to see healthy ways of using AI because they're using it anyway, and I want to make sure they can see some healthy ways of using it, not unhealthy, I guess, but maybe inappropriate ways of using it. I don't know, Dr. Boss, if you have other thoughts.
Dr. Bossy might have had to go pick up his daughter.
Oh, sorry.
Any other questions? Okay, well, if you come up with any, feel free to put them in the chat, and Dr. Presswich, you can monitor and maybe answer them. And then I will turn it back over to Dr. Moy.
Dr.
And
Moy,
you just
you're
need to
muted.
unmute.
Thank you. Sorry. Thank you to our amazing panelists, Dr. Bossy and Dr. Presswich. We're all learning together about AI, and your presentations have been a great start in helping ASCO's institutions to harness the power of AI in ClinEd and clinical practice. It's clear we need more time on this, and welcome your suggestions for future OCEF topics. Please keep an eye out for an email with the SurveyMonkey link and take a few minutes to provide us with some feedback about today's program. Thank you again to the OCEF moderators, ASCO Planning Committee, and ASCO staff for this wonderful event. I hope everyone has a great week, and it's May 4th, so may the 4th be with you. Have a great day. Okay. Do we stop recording?